Well, ladies and gentlemen, thank you for coming to Theater 1. Up next, we've got a presentation by SierraSil. Optimized magazine named him one of Canada's top 100 health influencers. He's married, lives in Vancouver, and is an active volunteer. Please welcome to the stage President of SierraSil, Michael Bentley.
Excited that Dr. Kam Shojania is here, and I'm going to invite Dr. Kam Shojania to come forward. 1 in 6 Canadians is living with arthritis, so it's a big issue. And whether you have it or you're looking after someone who does, it's probably affecting someone that you know. And so we are deeply honored that Dr. Shojania, who is on call today at VGH, is here to join us. Dr. Shojania is the clinical professor of medicine at UBC. He's head of the Department of Rheumatology at UBC. He's the head of rheumatology at VGH and St. Paul's. He's also the medical director for the Provincial Arthritis Program, the Mary Pack Arthritis Program. He is also, if that's not enough, you're in charge of the interns at UBC?
I just gave that up. I passed it on to an excellent doctor. Thank you. I passed it on to another doctor now. It was just too much.
Well, we are so delighted that you would join us today. Also, I'll let you know that Dr. Shojania, he's married to Anna. He lives in Vancouver. He's a dad. And we are thrilled that you would join us, even though you are on call at this very moment. So hopefully no emergencies while you're here, and you can stay with us for the session. The subject is the ABKs of living with arthritis. I hope you get the play on words for Dr. Kam Shojania. And what I'll do is I'll start with a few questions to open the dialogue up, and then we're going to turn the microphone over to you to ask questions of Dr. Shojania. Is that all right with everybody? Okay, great. So, Kam, have a seat if you like.
Thank you.
So we're going to start with, Kam, what drove your passion to study and educate and treat in the field of arthritis?
I was actually on my way to do cardiology, and I did a rotation in rheumatology, and I really became fascinated with it, so I switched right over.
Okay,
point.
Great. And how old were you when you could spell rheumatology?
Yeah. About that time, I realized that E and U, yeah.
Okay, well, great. So what is arthritis, and what are the implications for people who have it? And I'm just going to ask you to make sure you hold the microphone close to your mouth so everybody can hear.
I will. I think the most important thing is that there are 2 major types of arthritis. There's the type that many of us here have or getting, that's the osteoarthritis. So about 50% of us will be getting that at some point. I like to say on X-ray, about 50% of us at age 50 have some kind of osteoarthritis. That's the kind that most people ask me about, my friends ask me about when we go on a bike ride. That's the common one that we can talk about. But the other type that I see in my office and I get referred to are the other less common types of arthritis. Those are like rheumatoid arthritis, the connective tissue diseases that you hear about, like lupus or Sjogren's syndrome, or these autoimmune diseases. So I really think we need to separate those 2, because the common one, osteoarthritis, is treated completely differently than the rare types of arthritis.
So maybe you can just share what are the implications of a patient having, say, osteoarthritis or rheumatoid or one of the other arthritises, and how are they diagnosed?
So this is one of my big goals in the province of BC, is to get the people diagnosed early with both types of arthritis. So for osteoarthritis, the problem is by the time you get into your doctor or get referred, it's getting late, because the process has been happening probably 20 years before that, before you actually have symptoms. So sadly, we could prevent a lot of people from getting osteoarthritis if we catch them early. For rheumatoid arthritis, it's very quick. So you could get it at any age. Kids can get it. You can get it at average age is actually around 42. for rheumatoid arthritis, and that you really know something's wrong at that point. Something hits you very hard. It's like having flu-like illness with joint pains and very stiff and hard to function. That type of arthritis, we really need to see within 6 weeks. And for that type, we can treat and really put it in remission in most cases.
Is there an issue of gender on that as well?
Yes, actually, for rheumatoid arthritis, it's about 3 to 1 female to male. Osteoarthritis, it's pretty even. Both men and women get osteoarthritis.
And how is osteoarthritis diagnosed?
Well, normally you would come in and you would have pain in the small joints of the fingers, typically the knees, the hips, back and neck. Sometimes it's mistaken for other problems, but it is actually osteoarthritis. So osteoarthritis is more slower onset, maybe occasional exacerbations triggered by something and then settles down a bit, then comes back.
Okay. So when you've got a patient with arthritis and they've been diagnosed, what kinds of things should they be talking to you about?
Well,
or their GP.
Or their GP, because the vast majority of people with osteoarthritis are not going to be coming to see me. They're going to be seeing their family physician, or they'll be seeing allied health professionals. And what question should they ask? I think the most important question for osteoarthritis is, what can I do to improve my symptoms and prevent the need for joint replacement? Those are the most important questions to ask.
Okay, well, speaking of that, there are programs, for example, through the Mary Pack Arthritis Program that you're the medical director of. What kinds of services are available to patients with arthritis? Okay,
so for osteoarthritis, I think the best programs have to do with exercise and weight management if you're overweight. And those can be done through many community centers or local or even online. There is a program in Vancouver Coastal Health called OASIS, OASIS, and that is an assessment. I really like that program. It's an assessment by physiotherapists and occupational therapists for osteoarthritis, and then they will assess a person and give them a plan on managing osteoarthritis. I really like the OASIS program, and I'm hoping that other health authorities adopt that program.
So before we get into the sort of more the prescription drugs and so forth, tell us more about the lifestyle and diet choices that you want patients to be making to once they're diagnosed or even before they're diagnosed.
I have a amusing anecdote. Well, many years ago, I've been in practice for more than 20 years. Many years ago, I had a patient came in. I assessed him. He had osteoarthritis of the knees and hips. He was a little overweight. He was a little sedentary. And he came in and he said, "Now, doctor, I really don't want any pills. I really want to know some ways I can deal with this osteoarthritis." And I said, after I assessed him, I said, "Perfect. For this type of arthritis, pills are not really necessary." And I outlined the exercise program, the 4 pillars, which we can talk about, the 4 pillars of exercise. I talked about weight management. He needed to lose about 10 pounds for his hips and knees. We talked about diet and things to avoid and things he should take. After all that, he was sort of staring at me and he said, "Isn't there a pill I could just take?" So that's the problem. Lifestyle, all those things are important, but it's hard to get people to engage.
There's a pill that I would recommend, but tell us more about the 4 pillars then.
So the 4 pillars of exercise, because I have some of my exercise buddies, and all they do is is get on the bike, and they think they're doing a good job. Depending on your age, and a good kinesiologist is probably the best person to help you with exercise, but it's cardio, strengthening. As we get older, we lose muscle, and we forget that strengthening is super important. Range of movement or stretching. And the last one that people forget about is balance and agility. So all this stuff can help you prevent falls. The problem is, if you're kind of flexible, you love to go to yoga and do all that stuff. Well, you know what? You actually need to strengthen. If you're a stiff middle-aged guy like me, you don't like to go to yoga because you can't do it. In fact, that's the thing I should be doing more. So those are the 4 pillars.
So we should do what we're uncomfortable at.
Do what you don't like doing.
Okay. Okay, but now there are some people who do need medication. What are some of the medications that are available, and what should people know about those medications, and what do they do? Those kinds of questions.
So again, remember I said there's 2 types of arthritis, the osteoarthritis and the others. Well, for osteoarthritis, there are no medications that slow down the progression of osteoarthritis. Doesn't matter what people say, nothing has been shown to slow down the progression of osteoarthritis. When I was training 20 years ago, we were using a lot of anti-inflammatories, and in fact, they can be very helpful for symptoms. They do not slow down the progression, and in animal studies, they can actually make the cartilage a bit more damaged. I don't think that's been shown in humans, but in animal studies, they're not that good. So anti-inflammatories we used to use a lot more of 20 years ago. We realize now that they're not so safe long-term. We probably should not be using them on a regular basis, but they're great for flare-ups, especially if you've over-exercised or something's happened and you need them for a few days, that's fine. But they have side effects of bleeding stomach ulcers, worsening blood pressure, kidney dysfunction, and slightly increased cardiovascular risks. Those risks go up as we get older. So I think if you're 70, 75, you probably should not be taking an anti-inflammatory.
So for those of us who may not know whether it's an anti-inflammatory or something else, what would be some of the names on the bottle that people...
Thank you. The common ones over the counter that you will see are ibuprofen and naproxen, and then there are a lot of prescription anti-inflammatories. But just because they're over the counter doesn't mean they're safe. I don't know why some are over the counter and some are not. It's not a safety issue, I think, but those are the ones. Acetaminophen or Tylenol is not an anti-inflammatory.
Acetaminophen actually blocks pain receptors. It also blocks joy receptors, from what I understand. So if someone's using acetaminophen and say you're going to a daughter or son's wedding or something like that, you're probably not going to enjoy it as much as you would if you weren't using it, because it dulls sort of both positive and negative, and so which is something that's interesting that most people don't even think about. So, but again, going back to what are some of the prescription medications if someone's on? What would be some of the you probably don't know whether you have stomach bleeding or not. Are there some surface indications to know that you've reached your limit?
No, there are not. People assume that for bleeding stomach ulcers or gastritis, you will have symptoms, but about half the people with complications do not have symptoms. So and they're not that common. I say, I tell my patients that if you take this on a regular basis, if you're a young, healthy person, you have about a 2% risk of having a bleeding or perforating stomach ulcer per year. 2%, which sounds low, but as you get older, that goes up. If you're on a blood thinner, that goes up a lot. So you don't have to have symptoms.
I'm on a plane tonight, and I live in Vancouver as well, but if they said there was a 2% chance it's going to crash, I'm probably not stepping on that plane. So what about natural health products? Glucosamine is very common. It became very popular in the 1980s with Jason Theodakis' book, The Arthritis Cure. SierraSil has become our 180 capsule bottle size has become Canada's top selling natural joint care product. What are your thoughts on supplements?
There are many, many supplements out there, and I've been around for, like I said, more than 20 years, so I see lots of things come and go. So I really don't like hype. I just look at the science. And glucosamine has some science behind it. There's some, as you know, the Gates study in the New England Journal of Medicine has some science. It's about equivalent to an anti-inflammatory. It's not a panacea, but if my patients, if they're doing the lifestyle and the diet and the weight management and they need something else, I think glucosamine is quite reasonable to try. Tell them, try it for 3 months. The problem is it's 3 times a day. It's hard to take a pill 3 times a day. The combination, I think, in the Gates study, and I think you might know it better, I think it's glucosamine plus chondroitin together, 500 milligrams and 400. I think that's what classically they provide. 3 times a day is the dosing. So I have no problem with that one. With SierraSil, you guys did a very good study a few years ago. And what bothers me about some, and the reason, first of all, the reason I'm here is because Michael is an ethical guy with an ethical company that actually did the study.
Yeah, we actually have a few double-blind, placebo-controlled crossover studies. So.
Yeah, so that a lot of people don't put their money where their mouth is, and it showed some evidence of benefit. So I'm happy to I will only go by the science, and I like the fact that it showed some benefit. So I tell my patients, try it for a few months, see how you feel. If it doesn't work, you can stop it.
If it doesn't work, we give them their money back, so there's really no risk. Why don't we take some questions from the floor?
Perfect.
And do we have some questions? I have more that I can ask Kam, but we're really happy to get your input and your participation. The lady...
There.
In the back, oh, there's a couple questions.
Hi. Hello. Can you hear? Yeah. My question is, I'm sure the produce is pretty good. You know, I hear everywhere on the radio or people comment. But the only one part of I'm intrigued, it's the little piece of aluminum is there. It's a long term, like if you take more than 6 months, long term can disadvantage your health from the aluminum because no cancer and this.
So, ma'am, is your question, are there potential side effects with the long-term use of the SierraSil minerals?
No, there is some aluminum in your product.
Yes, so the question and the concern is there's some aluminum in SierraSil, and there is. It's actually in every food that you eat, particularly vegetables and fruits. It's also in your water and so forth. The aluminum levels in SierraSil are very low, and they're also, from when you look at bioaccessibility, which you would from a toxicological point of view, it's really truly insignificant in terms of your overall diet. And we've actually looked at long-term studies in terms of and high dosage studies, and there are not only no accumulations of aluminum in the body when using SierraSil at very high dosages, but also something pretty dramatic. It also chelates heavy metals like lead and mercury from the body. So it actually helps attract and bind heavy metals, and so you pee them out. And it's also why we say take SierraSil away from medications, because of that chelating benefit. So for the very reason that you're concerned is actually a good reason to actually take SierraSil if you're concerned about heavy metals in your body. There's a question here.
Hi, I know quite a few people who take the Voltaren cream for arthritis. What do you know about that cream?
The Voltaren or Diclofenac cream, yes, absolutely. Good point. That is an anti-inflammatory topical agent. You can buy it over the counter, or you could get a stronger version made up by the pharmacist. They can compound it. One of my colleagues, Art Bookman in Toronto, was involved in one of the studies for the Diclofenac cream, and I asked him, Art, how does a cream on top of the skin get down to the joint and make it feel better? And he said, you know, it's hard to know because they did a double-blind study and it showed benefit. So I said, I see the benefit, but I can't think of how it works. And he said, I don't know, because there's not significant blood levels. You don't get the side effects that the other anti-inflammatories do, yet it has some benefit short term, but it's there. So I don't know how it works, but I do recommend it. And it's safe for those people who cannot take the anti-inflammatory pills. Very good question.
Your colleague at UBC, Dr. Jack Taunton, says the one that's available over the counter that the questioner asked has 0.5% of active in it, and he describes it as, in his words, a joke. And he says to get effectiveness with that ingredient, you really need 10%, and that's 10%. What he gets made up. And so if you're looking for that ingredient, what Dr. Shojania talked about is go to a pharmacist who can put it into a higher concentration, because 99.5% of that product is filler. We do have a potential alternative product which costs a little more to purchase, but there's no filler in it. So on an active basis, it's actually pretty inexpensive compared to the Voltaren product, in my opinion. People are you're welcome to test it at our booth, which is near the door that you came in. We have a question over here. Did that answer your question?